going to be my great pleasure to be in conversation with a wonderful friend, colleague and mentor in Dr. John Beard today. In April 2023, John was appointed as the Irene Diamond Professor and Director of International Longevity Centre in the United States, and that's where he comes to us today. The appointment is the most recent of a career dedicated to international and national policy development in the area of population ageing. Initially, John worked in Australia as a physician in primary healthcare, including several years with an Aboriginal medical service. Some of you may not know, but from 1991, he held a range of senior public health and academic roles in Australia, including Manager of Public Health for the Sydney 2000 Olympics, followed by 3 years as Senior Epidemiologist with the New York Academy of Medicine in the United States. John, you joined the World Health Organization in 2018, and I think that's about the time that we met in Montreal. And for more than a decade, you were the Director of Aging and Life course, and you worked with all levels of government and academia in the 194 WHO member states. You are also Professor of Centre of Excellence on Population Ageing Research at the University of New South Wales, formerly member or chair of Global Futures Council on Human Enhancement and Ageing, the World Economic Forum, and member of the board of the Global Centre for Modern Ageing in Adelaide. John, you come to us today 3 years after you were our first speaker, our first expert in our global cafes. And I know that your workload stretches you around the world. So we're very grateful for your time this morning. So welcome to our Global Cafe.
Thanks, Jane. It's really great. I think these cafes are a terrific initiative of IFA. So it's great to be back. And I don't know where you found all that information on me. It's I tucked it away somewhere in the past.
Yeah, don't worry. The internet means that you can't go anywhere without everything about you sitting there. But John, I want to start with this word retirement. It's a word that doesn't sit comfortably with you, and I've heard you talk about it before, but in some ways it speaks to the heart of this global cafe. Let's stop boxing older people in. So the question really is around how you have advocated for awarding old age benefits on the basis of functionality and socioeconomic status rather than on chronological age. Can you talk with us a little bit about this concept of, old age benefits on the basis of functionality, and what will it mean to transition to this?
Okay, yeah, I mean, I think, and the title of this discussion captures it for me, in that what we tend to do as a society is categorize people as old. And typically by chronological age, and we assume that everybody over that chronological age is the same, and they have the same needs and the same aspirations. And yet that's entirely false, because chronological age doesn't determine your aspirations. It doesn't determine your capacity to be able to do things. But everybody in the second half of life has a need for security. They have a need for financial security, a nice place to live, and so on. But many will also want to continue to be part of the workforce. And yet we have created this artificial structure, a life course, where typically people expect to study till they're 25, work till they're 65, and then retire. And we box people into that last group, even though it may not fit for them. And, I think I'm the classic example. I was at WHO, enjoying my work and would have happily continued, but I hit their mandatory retirement age and was prevented from continuing to work simply on the basis of my chronological age. And despite either my aspirations or my circumstances, at the time I had a 5-year-old child to support. And so what I think is really important is that we break down those rigid categories and start to think of life as a continuum. Now, doing that is much easier, it's much easier said than done, because there are many people, and you only have to look at France at the moment to understand that many people want to retire, Others don't want to retire. Some people are forced to keep working even though they may have severe physical or cognitive limitations. And somehow we have to find a way of moving forward that allows for that incredible heterogeneity, is fair and just, and doesn't reinforce inequities. So I think the key thing here is to avoid mandatory anythings. That's the first step, is to give people the option. But also, I mean, I think it's fair. One of the concerns you would say, for example, if you remove a mandatory retirement age, is employers will be concerned, well, people will just keep working even though they're not delivering. So somehow we also have to consider how we ensure that people are still performing the roles that they're meant to be performing, and not just continuing on because they've got the opportunity to do that. And then on the other hand, we have to be thinking about people who have limitations of function and need support in different ways to ensure financial security. So it's really complex, and I don't think there's a simple answer. But I think the first step we have to do is break away from this rigid framing of the life course and defining policy as if those life course frames were laid down in stone.
You know, what I believe is one of the most groundbreaking reports of my time was that you led, the WHO report on aging and health in 2015. And I still use it. You know, it's a marvelous reference document. There are 3 different domains in that, though: functional ability, function, intrinsic capacity, and environment. And I think it's really important if you could actually talk around those 3 domains and the interrelationship that they have, because that also speaks to, you know, what you've just talked about. So can you actually unpack that for us a little bit?
Sure. Yeah. Well, thanks for acknowledging the report. So the overarching goal of that was stated in the report of healthy aging was to build and maintain the functional ability that enables well-being, the functional ability that allows people to be and to do the things that they value. And we said in the report that functional ability had different components. Part of it is related to the individual, and we called all those individual level attributes intrinsic capacity. But part of it is related to the environment that the individual inhabits. So for me to see you on the screen, I actually need glasses, and to sit here, I need a chair. So to do the things I want, it requires an interaction between me and my individual attributes, my intrinsic capacity, and the environment I inhabit, and then I can get on and do things. And the reason we did that, this was very much drawn on the work of Amartya Sen and his on capabilities, was to try and shift governments from thinking about defining what older people should be to understanding that their role is actually to foster the abilities to do what they have reason to value, to do what older people themselves would want to do. And as I said earlier, that's incredibly diverse. But it's not government's role to define whether they should be in the workforce, whether they should be volunteers, whether they should or shouldn't be in care, and so on. The role of government is to provide all the resources possible to, just as they do across the rest of the life course, to enable people to participate and engage and do the things that are important to them. And I think that's an important shift when you start thinking about policy. And if you're thinking about retirement policy, it's a little bit the same. Instead of thinking about, okay, retirement is a mandatory thing at a certain chronological age, everybody gets a pension, and then people complain, well, there's more people and we can't afford it, so, you know, we'll have to raise pension age. Instead of thinking from that perspective, governments should be thinking about how they can foster abilities in all sorts of different ways, like lifelong learning, maintaining health, creating supportive environments, and so on. And I think it's a mind shift that's quite significant, and it leads to very different interventions.
You know, just moving on from that, and I can visualize the public health framework of action and the 3 different trajectories that was so well defined in this document. And it really speaks to the importance of public health actions at any time of life. Could you just describe those three different trajectories? Because it does relate to resilience and healthy aging, equally to the kind of services that we need to have provided at a community level and at a residential level. So can you talk about those three trajectories?
Sure. So what we said was, if you look at any population in this people in the second half of life, they will tend to fall into three distinct categories. As I said before, what we tend to do is say, okay, everybody over a certain age is the same. But if you look at that population group, you can generally separate it into these three categories. The first is people with high and stable capacity, people who are robust. The second is people who are starting to experience declines of capacity, and these are people who are often also experiencing multi-morbidities, complex chronic conditions, which require management. And then the third category is people who have had significant losses of capacity and who will require care and support. And so the interventions which you would hope that a government would put in place would target each of those separately. And let me give you a couple of examples. For the robust group, the key thing here is to keep them robust as long as possible. So this is where screening is important, early intervention for conditions and so on. But it's also a time, because the other thing we thought of as we looked at these three groups is there's some things you can do to foster intrinsic capacity, but there's also environmental things that you can look at that might be important. And for this robust group, the thing that's really often limits their ability is social attitudes, ageism, and issues like mandatory retirement age. So what we need to do in terms of the environment for that group is think about how we can break down those barriers to their ability. For the second group with declining capacity, we need to focus on how we can maintain their capacity at as high a level as possible for as long as possible. And that requires a complete shift in the sorts of health services which we have generally provided. So most health services have been developed to respond to acute conditions, injuries, and to cure them. And now, though, for most people in the second half of life in this group, they have these complex chronic morbidities which require much more integrated care. And so we need to redesign services so that they can provide integrated care rather than responding to each condition separately, and do it in a managed and ongoing coordinated way, which we know has the best outcomes. So we need to completely reframe the health system to be able to deliver that. This is also when the role of the environment becomes very important in a different way, because the environment can help people to compensate for or adapt to losses of capacity. And so, somebody who's got hip arthritis and finds it hard to get around, if there's disabled access public transport, they can still get where they need to go. And if there's seats on the sidewalk or toilets that are readily available, it's much easier for people with declining capacity to be able to get where they want to go. And then the third group, which is one which is so often overlooked, this is the group with significant losses. This is where we need to be thinking about developing better systems of long-term care that can help those people continue to live lives of meaning and dignity despite those significant losses. So splitting that group of people in the second half of life into those different categories, I think, helps tailor some of the interventions we can think of so that it meets their diverse needs.
And of course, when you talk about long-term care, that's just not, you're not referring to residential facilities, are you?
Oh, no. I mean, when I talk about long-term care, I'm thinking about every form of care provision, whether it be by family, whether it be by community, whether it's paid, unpaid, trained, untrained, going right through from the person's home, the community setting, through to more institutional care. And I think the problem when we talk about long-term care, and we found this when we wrote the chapter on long-term care for the World Report, we were trying to frame it, and what you typically do is come from a service perspective. You think about the different people who provide care, and then you try and frame what needs to be done. But what I think we did, which really worked well and really transformed my way of thinking in the report, was we really tried to think of it from the person's perspective. So the whole of this second half of life course is very much person-centered. And then we look at, okay, what are the things that are necessary to enable the abilities of people with these different capacities to the best that we can, rather than thinking about, okay, I've got these services, how can we provide them to a homogeneous bunch of people that doesn't really exist.
And what you've really identified there is the work of Islani Di Carvello in the development of the Integrated Care of Older People guidelines, which is growing today, and also the leadership, of the Global Network of Age-Friendly Cities and Communities. So they're two of the action areas. John, as I thought would happen, there are a load of questions coming in at the same time as we're talking. So rather than leave them to the end, I'm going to ask people to come forward and we'll have a bit of a conversation. So Antonio Carvalho, would you like to come forward and ask Dr. Beard your question? Are you there with us?
Yes, I am. Thank you.
Good morning.
Good morning. Thank you very much for the lecture. I totally agree that we should provide a great variety of options. So my point is, and my question is, wouldn't that be the role of the governments to really define a policy towards, for instance, public space and public transportation, which by definition is something that the governments and public entities should take care of, instead of defining roles for the people's lives, which is something private that each one needs to decide on his own. I usually work, I am an architect, and I teach design studio for my students about how to design spaces for older people, both public space and the housing spaces. But today I would not, for now, at least I would not go into that, even though I find it crucial to offer people diverse, different possibilities. I would like to understand about policy, just that.
Thank you very much, Antonio. John?
Okay, yeah, Antonio, unfortunately I lost you at the critical time of your question, but I think what you were saying was very similar to what I was also trying to say. The reason we developed this different way of thinking for the World Report on Aging and Health was because governments were actually doing what you were describing and defining what we should be doing at certain stages in our life. And the critical issue here it started with retirement. And for example, in the EU at the time, there was a very, oh my goodness, sorry. there was a very heavy pressure to, yeah, okay, it's gone now. There was a very heavy pressure for people to continue in the workforce and to increase retirement age, and there still is. And so what was happening was, and governments were evaluating their success by their ability to increase people's working lives. Now, that has some good sides. For people like me, I wanted to continue working, I'm robust, and I get a good income, I've got an interesting job. But for other people, it's not the same situation. Other people may have had heavy manual labor all their lives. Physically, they may be wearing out. And frankly, who wants to continue doing that? So what we were trying to do was shift government's focus from the outcome that they were defining to saying, if you can invest in maintaining capacity and ability, these older people will invent lives that you can't even imagine. And they are an incredible physical and social resource. They bring all sorts of creativity, and there will be all sorts of positive benefits. You shouldn't be defining them. It's your responsibility to look after your citizens in a way that enables them to create these new lives. So I think we're saying the same thing, and I think architecture is a very important mechanism for doing that, and one of the things that the Global Network of Age-Friendly Cities has been trying to encourage is thinking about how we can design urban spaces and buildings in ways that allow people to do more.
Look, thank you, John, and thank you, Antonio. I'm just asking whether Trish Finnegan is with us. Trish, I know that you had to leave a bit earlier.
Yeah, I'm here.
Okay, Trish, yeah. Would you like to ask your question, Trish?
Yeah, I saw this piece in the Irish Times yesterday, which is one of the big national papers here in Ireland, around aging in Europe in particular. And I've put it in the chat there, linked to the Twitter. It really struck me because I was infuriated by the language that was used around, and very ageist language, and in particular around, you know, pension time bombs and, oh, young people having to support older people. I'm a PhD researcher in the Southeast Technological University in Ireland, and my area of interest, my research theme is age-friendly universities. So I've been doing a lot of research on it, and I just wondered what other people had thought. So I put it in the chat, but I need to take my 86-year-old mother back to her. She had a cataract operation yesterday, and I need to take her back because she can't drive. So I need to leave at 12:30, and she is a model for healthy, active aging.
Thanks very much, Trish. I think you know, the question, John, is around language that we use, and I know that ageism, combating ageism, is one of the key action areas. So could you comment on the power of language and discrimination?
It is so important, and this was another thing we tried to tackle with the World Report. This and essentially what Trish is describing is this framing of the life course. So you have a chronological age, everybody above it are the same. They don't, once you're above an age of 65 or whatever, you are retired and you don't contribute. And so you're a burden on society, a fiscal burden on society, and you're placing limits on the development of society more broadly, and particularly younger generations. And I have to tell you, it's absolute false. It's just, it doesn't, what happens is, because we start with this framing, this rigid framing, you end up with hypotheses and with research questions which are designed based on a false perception at the beginning, and you end up with answers which are predefined basically because of the way you've defined the question. And so, I mean, just on the specific points, the fiscal sustainability, first of all, there is very little research that's undertaken to actually look at the contributions of older people. They contribute in all sorts of ways, including paying taxes. You know, everything an older person buys in many countries is a value-added tax is included. Older people often pay income taxes. Many self-funded retirees are not a financial burden on the state at all, and all older people continue to consume, which reinforces the economy. Older people are also creative. The most successful entrepreneurs in the United States are not your young 20-somethings at 50, because they're people who have the experience to make good judgments and so on. So the research that has been done, and there's a study in the United Kingdom, shows that those contributions actually outweigh the cost to society financially. So first of all, even coming from that framing, the answer isn't what the politicians will say. And another way of looking at it is in terms of gross domestic product, and countries like Germany, which are very rapidly aging and have now reached a population structure where the proportion of older people is much greater than will ever be the case in the United States. Germany's put in place universal pension, universal health care, mandatory long-term care, and universal long-term access to long-term care. And their gross domestic product has outstripped the United States at a per-person purchase parity pricing comparison over the last 20 years. So there is no economic argument to reinforce what Trish was saying. And I think all of this comes back to the language we use and labeling older people, retirees, putting people in boxes, instead of thinking about a life course that's a continuum where people at any stage in life may want to study, may want to have some time out, may want to spend time with family, may want to work. And what we need to do is break down that disintegrated continuum and think about how we can support people across that life course.
Look, thank you for that. Now, John, I want us to go back 3 years, and we're really at the beginning of an unprecedented time in our world. I didn't ever think that we would be in lockdown for 1 year, 2 years, etc. You know, there were many complex issues raised during the pandemic about the balance between removing restrictions on social behaviour while protecting those that were most vulnerable. You know, in Canada, most of those that died were in long-term care facilities, all very vulnerable. We didn't do a good job in this country, in my opinion. So is this a question of equity, addressing ageism, or perhaps protecting an already stressed healthcare system? What was it? Was it all of the above? And if you were responsible, you know, at WHO, perhaps you were the DG at the time, you know, what would your thinking be, you know, going into this pandemic? So 2 questions. What are we talking about here? Equity, protecting healthcare systems, addressing ageism, and what would we do differently?
Okay, I think you're right. It's all of the above, but equity is one of the fundamental issues here, and you've got all sorts of different types of equity. You can, and Trish was raising what other people often point to as intergenerational equity, but there's also equity across each of our lives. And if you look at, we talked about those different categories that people might fall into in terms of their capacity. The people in the lowest groupings of capacity aren't there by chance. At any given age, the people with the worst capacity often have experienced the cumulative impact of disadvantage across their lives. And so the reason they're in that needy group is because of the inequities they've experienced across their life course. And often the policies we put in place can reinforce those inequities instead of addressing them, which you can do for people in older age. So that's number one. Number two, the problems which, I mean, there were some real triumphs with COVID. I mean, getting vaccines up and out, and, you know, it's really amazing what the world was able to achieve. But the problems came because our systems were really badly designed to meet the needs of the populations that they now serve. And then badly designed in many ways. The first one is, in many countries, there'd been a systemic disinvestment in long-term care and support for vulnerable older people. More and more money was going into high-tech hospital tertiary care, and less was going into social care and the support that those vulnerable people need. There's then a disjunction between social care and healthcare. And so often funded through different funding mechanisms. And so there's cost shifting within government. Everybody in hospitals wants to get old people out into the nursing home so they don't have to pay for them, and vice versa. And so because we have these disintegrated systems, it's really hard to mount a comprehensive, cohesive. And so in some countries, what you saw was people from nursing homes were not being admitted to hospitals because they were identified as, well, we don't want to waste money on them. We want to make sure young people survive, and then sent back to nursing homes with active COVID infections. And in the nursing homes, people were not trained. There wasn't the emergency preparedness which is necessary to address a challenge like COVID, and so there's also this systemic dysfunction which meant we weren't able to respond in the way we should have. And then on top of that, there is I think over emphasizing of the risks of, if we spend all the money supporting older people, we won't be able to keep younger people in work, keep society moving, and so on. I think, in hindsight, and you've got to remember all this panned out not in hindsight. It was day to day and nobody really knew what was happening. But in hindsight, it's clear we had enough resources. We just didn't have a system in place which could address the issue in a way that was cohesive. And then on top of that, you had politicians come in and use that divisiveness for their own political ends, which reinforced some of the negative ageist attitudes that were a starting point for some of this dysfunction.
And that's the very reason why, combating ageism is one of those key 4 action areas of the decade. I'm going to turn back to our cafe attendees and ask Jim Hamilton and then Denise Schwang. So Jim, would you like to come forward, and then Denise?
Sure. Thanks, Jane, and great dialogue, and good to be part of it. Just wondering, John, your sense of, certainly value the World Report. I think it's interesting that age-friendly communities came 10 years before the World Report, and actually the World Report points us back to age-friendly communities as one of the key answers to supporting that functional ability. I still see us challenged by, and I'm wondering from your perspective, how important is it to engage the voice of older people around that dialogue of shifting from the sense of cost to that sense of investment and that return on the investment? So all things age-friendly communities, long-term care, ageist attitudes. How do we get older people more engaged in that conversation? Because I see that still as a continuing challenge with the work that I'm connected to.
Yeah, I think it's absolutely critical, Jim. And it's not just with government. I think I've, since leaving WHO, I've done a fair amount of work with the private sector. And it really sometimes shocks me how little the private sector understands older populations. They don't understand the market, the needs, and how they can develop products which might meet those needs. And in the private sector, the equivalent of the voice of older people is co-design. And there are a number of places which, and the Global Centre for Modern Aging, which I work with in Adelaide in Australia, is very heavily focused on this, which actually are starting now to look at how you can incorporate the voice of older people through co-design in the development, in work of the private sector in the development of products. It's not just government, but it's also absolutely critical for government. And one of the things I learned from the Global Network of Age-Friendly Cities was the importance of engaging with older people, because even at a municipal level, decision makers often come to decisions with stereotypes. And those stereotypes, they may have fitted one person, or they may have been appropriate 20 years ago. They're not necessarily appropriate today, and they don't necessarily understand or meet the needs of the broader population that they're having to make decisions for. So engaging with older people in trying to develop programs and to frame some of the decisions that are ultimately going to impact them is absolutely critical. It still doesn't happen enough. There are a lot of mechanisms. It's hard. Because then the risk is you have one small group of older people that becomes the people you go to, and you don't actually consult more broadly, but you go to this one limited group, and they don't know what everybody wants either. One of the things that I really enjoyed when I was in New York before moving to WHO, and they were doing the developing age-friendly New York at the time, was they used to have town hall sessions where they brought older people together, and they used to have other meeting mechanisms where older people would come. And it was fantastic. They were so outspoken. Well, it was New York, maybe that was a part of it, but they were so outspoken saying, no, this is not what we want. We want this, and you haven't listened to us. And so mechanisms to enable that broader engagement, I think, are really critical.
And I just want to acknowledge Nancy Hoden, that's on the line today from the Global Coalition on Aging. And John, you're the chair of the Global Coalition on Aging. So Welcome, Nancy. I'm going to go to Denise, and then I'm going to ask you a question about celebrating the 75th anniversary of WHO. So, Denise?
Good morning. Mine was more a comment just about the vulnerable use of the vulnerable word. I remember a talk by Ross Upshar at the Global Café. He talked about speaking with older people, and they're right off the bat, they explained to him that you're making us vulnerable by the position you're putting us in. And if you give us choices like how to use machines in the hospitals, we can choose. We're smart enough to make our own decisions of where the best use of hospital resources should go. So I think, yeah, that was maybe my comment, is just that we do have underlying ageism, but I think our lack of will to stop and reconsider what we mean by the word vulnerable. Just saying we need to protect the vulnerable, but what does that mean before we slap on a bunch of ideas on what's best for them?
Okay, thank you for that.
I like that a lot. And I think also, but I've always found this challenging because as I've tried to reinforce, older age is a period of incredible heterogeneity, incredible diversity. And we've seen over the last 50 or 60 years, big shifts in the way we stereotype the group. In the 1950s, everybody just assumed that people over the age of 60 were weak, vulnerable, and frail, and they didn't contribute. But there weren't many of them, so we could afford to try and give them some sort of retirement benefit. As we moved through, older people pushed back against that, and they said, hang on, I might be 60, 65, 70, but I'm not vulnerable or weak. I can still contribute, but you're not letting me do it because you're stereotyping me. And so there was the pushback to really try and frame older people in a more positive light. But the risk in doing that is that there are, which I fully support that, of course, because I hope I'm living what people were preaching. But the risk in doing that is there are still people who are vulnerable in whatever sense we want to use the word. And I agree that it's complex, and vulnerability, in fact, is not just an individual level thing. It's also about the people's engagement with their environment, their autonomy, their agency, and things like that. But there are some older people who require significant care and support if they're going to continue to live lives of meaning and dignity. And somehow we have to embrace all of that diversity and talk to decision makers and providers and get them to understand that, yes, you've got to break down the barriers and support the people who can and want to be engaged. But you mustn't forget that there's a portion of the population that actually still we need to focus on in a more supportive way. And that's, again, why I think breaking the second half of life into those three groups has been very useful. And Jane, thank you for acknowledging that Islena Aruja de Carvalho was the person who actually came up with that framing. I found it really, really helpful.
Look, this is a beautiful segue into a question from Dr. Bill Reichman, CEO of Baycrest. So, Bill?
Yeah, thanks, Jane. So it seems that there's reasonable consensus that using a chronological age barrier as the definition of a life stage isn't very sensible, given heterogeneity and some of the other points, John, that you've been making. But we do seem very, very comfortable using terms like, older adult. And I guess I'm trying to understand, what do we actually mean by that term? What do we mean by an older people or older adult when a 46-year-old is older than a 43-year-old? So help us with that definition.
Yeah, thanks, and thanks, Bill. And when we wrote the World Report on Aging and Health, we tried to be, I guess, politically correct, and we used the term older people or older adults. And then when we finalized the report, we realized we needed a glossary, and we realized this was a term we had used repeatedly through the document. And we wanted to define, we thought we have to define it, but we need to define it in a way that's not ageist, that doesn't reinforce the things we're battling against. So the way we defined it was an older person was someone essentially who is in the second half of life, who was someone who was over the median life expectancy in the place where they lived. So it was variable. If you lived in a place like New York, then if you're over 41, 42, then you would fall into the category of older people. Whereas if you lived in a place in Africa or a very poor setting, a shorter life expectancy, you would become an older person at a younger age. And so rather than defining it by a specific chronological age, we just said it was the second half of life. And that actually also makes sense conceptually, and it worked well with the framework which we'd created about how people can think about the second half and look at their progress, not necessarily linearly, but through those or into those different stages that I talked about, and hopefully encourage people to think a little bit more early about the things they should be doing to maintain and build capacity, rather than waiting till they're old and responding at that stage. So it works for me, and then I feel comfortable using the term. But but the moment you define whether somebody's older or not by a chronological age, you're wrong, because chronological age is only very loosely tied to the characteristics which we would associate increasing.
Look, thank you very much. John, I wouldn't be doing justice to the work of my colleagues in New York over the past few days and 10 years before by not asking you a question that relates to a convention. So one of the key messages from WHO in celebrating the 75th anniversary, and by the way, IFA is 50 years old this year, was to demand your right to access the health services you need without falling into financial hardship. That's a big call by the WHO. But considering many millions of children are born into poverty, and those very children will grow perhaps into middle age, but will die prematurely in poverty, are we calling, is it the right time to call for a convention on the rights of older people? Or should civil society call for each and every government to be accountable for the lives of all of their citizens, but most particularly the rights of older people? So any thoughts? Which side of the fence are you going to be on? You can't be in the middle, John, all right?
But can you embrace everything? You cut out for me a bit in the middle of what you were saying, but let me have a few comments. First of all, I strongly support the idea of a convention on the rights of older people. The World Report on Aging and Health was a rights-based document. All the work we did is rights-based. But on the other hand, even though there does seem to be progress being made, and congratulations for everybody for moving it along, it's still a long way off, and we have to do something in the meantime. And there are framings which we can build on. I mean, the Declaration of Human Rights actually specifies discrimination against people for a whole range of things. It doesn't specify age, and it's a shame that that is one thing that should have been included, but it doesn't exclude it. And it seems to me that there is a hook there to push governments to act on. But I also think we need to be pushing them to act just because it's the right thing to do for their population. And my concern about both the convention and WHO's statement is that doing that isn't just more of the same. As you described with the COVID outbreak, we could have had more hospitals and even more nursing homes, but we would have had pretty much the same outcomes because the systems are dysfunctional. They're no longer designed for the populations that they increasingly serve. And we need to reinvent those systems so that they can actually support people across their lives. And if we're going to have a convention, we have to be really smart so that it would be framed in a way that actually pushes governments to do that transformation, not just to think about, we just need to have better access to what's already there, because what's already there is broken. You know, if you go to healthcare in many developed countries, you will be treated for one specific condition. Those conditions will be treated independently, and you will end up with polypharmacy, no holistic understanding or integration between the care you receive. You know, this is not what we should be pushing governments to do. And the risk of, if we're not really clever, is that we will just get more of what's dysfunctional.
Look, thank you for that. I'm glad that you're on our side of the fence. And you can have it all, but we're at the pointy end of this discussion, and I just want to call on Margaret Gillis, President of ILC Canada, who, with many other colleagues in New York and around the world, you know, we're talking about a convention. What should we be calling for, Margaret, and how can we use John's influence in this whole process?
We have all kinds of plans for John now that he's back in New York and at ILC USA, so watch us. But I think there's some really important things happening. One of the things that we had been complaining about as civil society was that the discussions at the UN had sort of turned into gerontology classes, but, you know, gerontology for economic students. Like, you know, it wasn't even really all that in depth. And I think there was a frustration level that was growing, and I think it really came to fruition this year. We had a lot of activists who we were very connected this time. And there was a decision at the beginning to have a decision taken with respect to moving forward on looking at gaps, which, you know, we're probably all rolling our eyes because we all know the gaps, but apparently this member states need to learn the gaps. But that decision was disrupted by Russia and others. Civil society took a really firm stand with our governments. We demanded that document decision include us as people that have to make decisions, you know nothing without us, without us. And so that had been changed by or suggested change by the Russian governments and their colleagues. And we pushed for our member states to go in and change that back. They also changed the date of the decision, and we thought they were trying to run out the time on the meeting so that we couldn't get the paper out. But we won that through really strong questions and pressure from all of us activists around the world on aging to our governments and also on the floor of the UN. So I think we all can pat ourselves on the back because a decision was taken to move forward. And what that will do is have two co-facilitators, one from a developed and one from a developing countries, who are leading that discussion intersessionally to start to move forward on the human rights of older persons. So, you know, that was really important. You know, there was a little side thing happening with Canada that I think was really interesting this year, and IFA and ILC Canada and a number of the larger aging organizations in the country came together this year with the help, of course, of IFA at a meeting in Toronto where we came together to say that we wanted to talk with one voice to the government of Canada. And there was 15 large organizations, and we're trying to expand that. What happened was we put pressure on the Canadian government. We got the Minister for Seniors there for the very first time. We had a very good session with her, a side event also, which we co-facilitated with IFA. And we really put our cards on the table about Canada taking a leadership role in terms of human rights, as we have done. We brought a lot of those new organizations to the table. So I think we're seeing a bit of a groundswell in Canada, but I think that's also happening internationally. Okay. And it's the real power of working together.
Okay, look, thank you for that. I'm going to flip that now, John, and I'm going to say, John, you have worked with governments all around the world. You've communicated with presidents, prime ministers, ministers of health, etc. You know, what is it that they listen to when you speak? And how does that link to this conversation about a convention? What do they listen to? You're going to Cambodia, you work in Singapore. So what is it that they want to know from you that we could, you know, use in our discussions?
Okay, I mean, it's a good question. I don't know if I have the answer. So it just seems to be chance many occasions when people suddenly, you know, their mother gets dementia, so suddenly there's a program on dementia or and so on. But I think to me, there's two particular things. One is this is an incredibly complex area, as we're talking about. And the risk is, and what's happened in the past, is it's been oversimplified. And that oversimplification has led to the dysfunctional systems we currently experience. But if we present governments with a complex issue, it becomes too much for them. They can't grapple it. And so what we have to do is somehow push through that complexity to a simplified vision and a simplified way of framing what needs to happen that's not simple, but incorporates that complexity and distills it to some key messages. And so I think we've got to, number one, be careful that we just don't ask for everything. We need to ask for some really critical things which we know will lead to a cascade of change, and identify what those things are. The second one is it's just always so obvious that money talks. And that we heard what's in the papers in Ireland, and you read this in the papers everywhere. These pseudo-economic arguments, which aren't really economic, they're fiscal arguments, and they're based on outdated stereotypes. And I think we need to develop much more real and much more effective messaging around the economics, because there's a strong message that older people contribute. The way we're currently dealing with things is actually impeding economic development, and that we need to reframe things in a way as governments would with other economic decisions. So one is really distilling the argument to identify the critical things which we want to happen, which we know will then cascade through to other change. But we don't have to talk about the other change. We don't have to try and convince governments to do all of that. We just need these critical things happening, which we know will then lead to that further those further results, and developing our economic argument. If you want to get governments to change, they're the things I think will help. And also building relationships. Politicians often like relationships, and this is where I think the role of civil society is really important, is reaching out to local politicians. I think it's part of the reason that the Global Network of Age-Friendly Cities has been such a triumph, because local politicians have been linked to local NGOs, to other civil society inputs. They're very close to that sort of thing, and I think we need to be thinking about that at all levels of government.
Look, thank you, John. As we wrap up, and I know that you're desperate for a coffee, so thank you for dealing with tea instead of coffee. Look, I have a question for you. We're about the same age chronologically, John, and you left WHO, not out of your choice. So, and you've embarked on a new stage of your life in New York. What are your ambitions and milestones in the next station of your life at Columbia, but most importantly, beyond your work? Because so many of us here today, are our work. So I'm really curious, about what does Columbia mean for you, your position, and beyond?
Okay, well, thanks for the question, Jane. I mean, in the World Report on Aging and Health, when we framed functional ability, we said one critical component was the ability to learn, grow, and make decisions, so that you can retain agency in your life and you can continue to grow and learn. And it's my underlying ambition that I will continue to do that until my last breath, that every moment will be a learning moment. And I've also learned across what is now becoming an increasingly long life that you can't actually predict what's coming. You never know what's around the corner. So you have to be open to all sorts of opportunities and changes, and you need to adapt. And this was a bit of a surprise that this opportunity came up. I realized when it came up that I'm very passionate about rigorous academic work. Particularly research, and I'm particularly interested in research comparing the experience in different countries, comparing health trends in different countries, and also trying to think about health not through the lens of the presence or absence of disease, but through the presence of functioning. So in terms of a research focus, I'm going to be pushing with that in that direction. I also feel, and numerous people have reported that this tends to happen as you get older, a desire to give back and to pass on my experience to other younger people or less experienced people in ways that sort of makes the world a better place. So in terms of my work at WHO, I see this core research component, and trying to ensure that the work that other people do is evidence-based. We're continuing to work with policymakers around the world to try to refine their work so it's as impactful as possible, but also trying to work with other people to support them to develop their skills so that this movement can continue and grow. And then personally, I really believe in work-life balance. I have an 8-year-old son that I spend a lot of time with, and I want to keep doing that. And I also will explore different aspects of my personal development and continue to grow there. When I lived in New York previously, I used to go to the Art Students League of New York in the evenings and do night classes in painting. And who knows what will happen now I'm back here. New York's a pretty amazing place.
Well, John, yes, it is a pretty amazing place. And you're a pretty amazing human being, because on the call today, we've had many people saying congratulations and thank you, and here I am. And what I've realised in my job is that my family is not based in Perth, Western Australia. My family is around the world. And, what I found in you is an unconditional generosity of sharing, the good, the bad, and the terrible, in terms of, how we can work together, but what we can do together. And so I thank you very much for your generous time today in coming back after 3 years. This Global Cafe will be, moved out to the world, and I'm sure we're going to get hundreds of people that want to listen to what you've got to say. And perhaps in another 3 years, we'll bring you back again to see what life in Colombia and New York has been. So thank you very much.
Thank you, Jane. And before we go, I'd just like to say, I share your feeling that this community is a big family. And, I bump into people in all sorts of parts of the world, quite sometimes unexpectedly. It's great to be part of that community. And also, I'd like to acknowledge, particularly on the 50th birthday of IFA, the contribution that IFA has made to actually.
Well, that's appropriate to lose
like this. So thank you.
Look, thank you very much, John. And as we close, we thank John and all of you today, and ask Luana to put up the slide for next week's Global Cafe. Please join with us. Dr. Lisa Menning from World Health Organization, we've just started working with Lisa, and she'll be our expert at the Global Cafe, talking about increasing uptake of vaccination, applying behavioural sciences and opportunities for action. So please join with us. My colleague Anna Sangster, Director of Policy, Advocacy and Innovation, will be moderating this important session. So join with us next week. And once again, thank you very much, Dr. John Beard, for being with us today. Stay safe and well. Thanks, John. Bye-bye.